We don't avoid refeeding syndrome, all these fluid and electrolyte shifts can result in cardiac abnormalities, arrhythmias, heart failure, cardiac arrest, seizures, weakness. Hi guys, my name is Barry. I'm a registered dietitian nutritionist and I'm taking over Kim's YouTube channel today to discuss the medical nutrition therapy for anorexia nervosa, specifically in the inpatient setting. Eating disorders, specifically anorexia, is a mental health disorder. So we approach these a bit differently, super sensitive, and everyone is different and they require different care. And that's why I'm going to be talking about the inpatient side, because it is a bit more standard than the outpatient. What is anorexia nervosa? And this definition is based off the ICD-10 codes. So anorexia nervosa is persistent restriction that results in low body weight. And low body weight is defined as 15% below what is expected for age, height, weight, gender, or BMI of less than 17.5. And there are two subtypes to anorexia. So either the restrictive subtype or the binge purge subtype. We see body image distortion and an intense fear of weight gain. There used to be a criteria for amenorrhea, which is the lack of a menstrual cycle, but according to the new DSM-5 codes, that has been eliminated. Why is the dietetic role so important in the treatment for patients with anorexia? So we are kind of the first line of treatment when it comes to the inpatient setting. So for example, when someone comes in, they're malnourished, but their brain is also malnourished. So their cognitive, abilities are not at the maximum efficiency. So things like before the doctor will even start to prescribe medication or before the psychiatrist begins therapy, they do wait until the patient is refed and the brain is back to a nourished state. So we're a very important part of the MDT, or the multidisciplinary team. Next would be following the nutrition care process, and I'm going to skip all the way to intervention because the first two steps of assessment and diagnosis can take a whole nother YouTube video. So I'm just going to skip to intervention. So our two main goals for an intervention would be weight restoration and avoid refeeding syndrome. So I'm going to focus on refeeding syndrome a bit for now. Refeeding syndrome is a shift of fluids and electrolytes that may occur when previously malnourished or starved patients begin to be fed again. So what happens was, prior to admission, the patient was in a state of ketosis due to a lack of nutrition. And then when they're admitted and we start to feed them again, it switches to a carbohydrate metabolism. And this switch can cause rapid metabolic changes in electrolytes like phosphate, sodium, potassium, magnesium. And these are all intermediates of, glucose breakdown. So think of glycolysis in the Krebs cycle. And when we switch, they're being used so quickly. And other things like cofactors like thiamine. So if we have a rapid depletion of thiamine, we can have a deficiency resulting in Wernicke's encephalopathy or cardiomyopathy. We can also have a buildup of lactate in the blood because it can't enter the Krebs cycle, and this can turn into lactic acidosis, which is dangerous for the patient as well. So if we don't avoid refeeding syndrome, all these fluid and electrolyte shifts can result in cardiac abnormalities, arrhythmias, heart failure, cardiac arrest, seizures, weakness, edema, etc. The list goes on, and it does put your patient at a high risk for survival. So we want to avoid that. So how do we do that? So we really want to make sure that we're identifying those at high risk for refeeding syndrome. And what makes someone at high risk would be minimal or no intake for 15 days prior to admission. So this is something that you would ascertain in the assessment portion of the nutrition care process. And also things like low electrolytes before being fed, again, in the biochemical data that you would obtain during the assessment, things like looking at the sodium, potassium, phosphate levels, and if they're low prior to being fed, making sure you talk to the doctor and ordering a prophylactic multivitamin. And then also patients with any BMI less than 16, they'll be at high risk as well. Is how do we feed these patients with avoiding refeeding syndrome? And it's definitely a challenge, and the first thing that we should always do is make sure we know what they were having prior to admission, because we never want to feed them less than they were already getting. So we normally start low. We start at about 20 kcal per kilogram, or even less if we need to, and we're always monitoring the electrolytes. And this is the great part of monitoring evaluation, because it's a continual process and we adjust as we go along. And we always want the diet to be low in simple sugar, because that will help the breakdown, the switch to carbohydrate metabolism is quick already, and that'll just speed it up. And then we want a diet that's low in fiber, because patients with anorexia already suffer from delayed gastric emptying, and the fiber will slow that down even more. But we also engage in nutrition counseling and education. That is a whole another YouTube video as well. So just focusing on the refeeding. We have to keep in mind that patients are often in a hypermetabolic phase during weight restoration, and even up to 1 year after weight restoration. And what this means is that their metabolisms are on overdrive. And so when we plug our data into equations like the Harris-Benedict or the Mifflin-St. Jeor, we might get a certain number, but we have to understand that it's going to be higher and we have to adjust accordingly. So someone's metabolic rate might come out as 1,500 to maintain weight, and we actually need to feed them 3,000 to 4,000 calories to weight gain, because their metabolism is working so hard to keep them alive. So that's important to keep in mind as well. So we do start slow and we build up to that. And we do have a food first approach, so we do want our patients to be eating their food on their food trays. If they cannot reach their goals and cannot eat enough, we do offer things like Ensure, Ensure Plus. We want things with high calorie, low volume, which will avoid the fluid shifts. And if they refuse to eat, the doctor may order a 2 feed, which is absolutely fine. And we always want to feed them, again, a formula that's high calorie, low volume to avoid the refeeding syndrome. And we want to feed them on a bolus feed. So this will mimic meal times, so then when we do phase them into solid foods. Our main goals were weight gain, ideally 1 to 2 pounds a week in the beginning phase, and then that can increase once we know they're not going to suffer from refeeding syndrome. And the other is to maintain the electrolyte levels within normal limits, so avoiding refeeding syndrome. So that is basically the MNT related to inpatient anorexia nervosa, specifically how to feed the patient. So if you have any questions, because I might have mentioned a few tricky terms, pop them into the comments section. I will get back to you. Remember to follow me on my social media platforms. So my handle is @BarryTheDietitian. And then also, don't forget to subscribe to Kim's YouTube channel and share this video. Thanks for watching.